Amy Kenyon. I'm one of the NICU educators at the NICU of Mercy. I'm also one of the neonatal transport nurses for Mercy One. I've been on the team for a couple of years. I've been in the NICU total since 2005, just in this CRN position, educator position for now almost a year. So I wear a lot of hats in the NICU, but definitely love what I do, and I love getting to meet all kinds of different groups and teams. So thank you for welcoming Molly and I out here to do these classes with you guys. So definitely feel free, if you have a question while I'm going through this, raise your hand, just get my attention somehow. I'm happy to stop and answer a question for you throughout this. Obviously, if you need to get up and go to the bathroom, I won't be offended whatsoever. So take your time and do whatever you need to do. So I'm just going to kind of go through some common neonatal emergencies. This is definitely just skimming the surface of the neonatal world. A lot of people get really, really intimidated by NICU stuff and tiny humans. So I'm going to try to make it as least scary as possible. So, so just a few quick definitions. Newborn is an infant within the first few hours of birth. Neonate is an infant within the first 28 days of birth, and a term newborn is usually between 37 and 42 weeks of pregnancy, with that golden week being the 40th week. So in the U.S., about 80% of the 30,000 babies born weighing less than 3 pounds require resuscitation. We usually say about 10% of all newborns require some sort of resuscitation at birth, beyond just the normal drying, stimulating, suctioning the airway. Short and long-term outcomes are linked to the initial stabilization efforts. So obviously what we do right there in the first minute to couple minutes is very, it impacts down the road. So critical care transport professionals must anticipate problems, just kind of have a good understanding of some things that might come up, be knowledgeable about how to deal with them, have appropriate resuscitation equipment readily available, and carefully consider the NEO's ultimate transport plan. So normal vitals for a baby. For a newborn, our respiratory rate, usually we're going to see 30 to 60, pulse 120 to 160, and then the minimal systolic blood pressure. It varies quite a bit, but usually we say right around the gestational age for the mean blood pressure. We usually want it a little higher than the mean, but we'll tolerate right about that at the same point. So usually if a 40-weeker has a mean blood pressure of 40, we're pretty happy with that. So thermoregulation is one of those big things that we always talk about. We always drive home to everyone. For a baby to get hypothermic is extremely detrimental for their long-term outcomes. We could be doing everything else right. If that kid gets cold, now we've got physiological processes that are slowed down. We've got all kinds of gas exchange impairment. We've got all kinds of metabolic problems that are going to start happening because they're cold. They lose heat a lot more easily than other kids do due to a high body to surface ratio, limited sub-Q fat, especially that brown fat that accumulates in the last month of pregnancy. A baby that's born at 25 weeks has very, very little to no brown fat, which is the fat that's metabolized to help them with heat production after birth. So that brown fat is mostly accumulated in the last 4 weeks of pregnancy. They also have a narrow range of a neutral thermal environment and very thin skin. Obviously, the younger the baby is, the thinner and less developed that skin is going to be. So we always try to use pre-warmed blankets and equipment, even just like pre-warming your hands if you can a little bit. If you're at a precipitous delivery or go wherever and mom's about to deliver, we try as much as possible to get a stack of warm blankets. I realize depending on where you are, that might not be possible, but if we can get a stack of warmed blankets, and then, when we dry the baby off, take the yucky, gross wet blanket out, and then you've got another fresh warm blanket right underneath it to kind of help continue drying and stimulating that baby. And so, like I mentioned about the brown fat metabolism, when the baby is working really hard to metabolize that brown fat, it actually causes them to consume oxygen more or more rapidly. We try to use an incubator or a transport, heat transport isolate as much as possible. So let's see what else we're going to talk about that. That's pretty much all I was going to say about that. So as far as respiratory structure and function, the national standard for viability is about 23 weeks. We have had babies born about 22 weeks that have survived not well, but we've had them before. Usually below 23 weeks is not compatible with life. Even at 23 weeks, the lungs are extremely immature, non-compliant, extremely difficult to ventilate without a lot of intervention. The lung is small relative to body size. And like I said before, with that chart, respiratory rate is usually between 30 and 60 with a tidal volume of 5 to 7 mils per kilo. So another few key points. The tongue is really large relative to the oral cavity, so a lot of times it can block the airway. Sometimes if you're not able to ventilate the baby adequately, it's because the tongue is in the way. Infants are obligate nose breathers, so we always want to suction the mouth and then the nose first, or mouth and then the nose. And then the larynx of neonates is more anterior than older babies and older kids. So when you're going to intubate that baby, just know you're going to have to be looking pretty high up anteriorly. Is that a word? Anteriorly? Anyway. Also, we want to look for defects too, like choanal Pierrot band sequence with a really small jaw. Sometimes those are going to be obstructions, but we'll talk about that a little bit later on. Managing secretions with the bulb syringe, if that's all you've got, that works just fine. So when positive pressure ventilation, or PPV, is needed, attempts should be made to maintain physiologic tidal volume breath. So we don't want to be over breathing for them. We don't want to give them such a high breath that we're going to give them the pneumo right away. Can cause volutrauma, hypercapnia, or hypocapnia. Especially the smaller, when we get into the smaller babies, it's easy to give too big of a breath. So we want to make sure we're being very aware of the volumes of breaths that we're giving. Do you guys use like the bags that have a pressure manometer built onto it, or like a PIP? PEEP. Well, we've a PEEP valve and like a PIP, so we know like what the volume of breath we're giving. Okay, just a PEEP. Well, that's great too, because that's definitely what we don't want to be giving too high of a PEEP either. So definitely just kind of be aware. We want to get chest rise, but we don't want excessive chest rise. We don't want like them coming off the bed with chest rise. We want just good equal lung expansion. So oxygen transport. Fetal hemoglobin forms 70 to 80% of the total hemoglobin in a neonate. The fetal hemoglobin delivers oxygen in the hypoxic condition in utero, but tends to hold onto the oxygen in normal conditions following birth. Neonates have high oxygen requirements. So when a baby is in utero, they're usually getting, their saturations would be between 50 and 60. So when a baby comes out and is blue, that's okay at first. A baby can take up to 10 minutes, a normal healthy baby at term might take up to 10 minutes to become pink, and that's okay. We have a handy, and I can send this over to Lee, but this is an NRP guideline, a neonatal resuscitation program, but it's targeted preductal sats after birth. So in the first minute of birth, or first minute after birth, a baby might still be pretty blue. It might be only 60 to 65% sats. It might take up to this full 10 minutes to get between 85 and 95. Usually they don't take that long, but they can. So we don't try to give as little pure oxygen to our babies as possible. If it's possible, we try to blend it starting at 21%. And we'll talk about that a little bit later on too. So oxygen transport is accomplished by cardiac output and a high respiratory rate. And neonates especially become hypoxic and bradycardic really quickly